The title of this module is Psychosis for the Nurse Practitioner. Psychosis and dementia is one module in the series of neuropsychiatric symptoms of dementia. Welcome to the education module, Psychosis and Dementia. In this module and throughout the series, the term persons living with dementia will be used to emphasize that dementia is a diagnosis and does not define an individual. Dementia is a highly stigmatized disease process. The term persons living with dementia is used to promote positive language and a more person-centered approach. The purpose of this module is to discuss the neuropsychiatric syndrome of psychosis. The National Institute of Health and National Institute of Mental Health describe psychosis as follows. The word psychosis is used to describe conditions that affect the mind, where there has been some loss of contact with reality. When someone becomes ill in this way, it is called a psychotic episode. During a period of psychosis, a person's thoughts and perceptions are disturbed, and the individual may have difficulty understanding what is real and what is not. Symptoms of psychosis include delusions or false belief, and hallucinations, seeing or hearing things that others do not see or hear. Other symptoms include incoherent or nonsense speech and behavior that is inappropriate for the situation. A person in a psychotic episode may also experience depression, anxiety, sleep problems, social withdrawal, lack of motivation, and difficulty functioning overall. A more basic definition of psychosis is a loss of contact with reality. Psychosis may be an indicator of delirium that is associated with an underlying physical illness or a serious and persistent mental health condition, such as schizophrenia. Psychosis is also a very common feature in a major neurocognitive disorder. Dementia is a major neurocognitive disorder. Approximately 40% of persons living with Alzheimer's dementia experience psychosis. Persons living with dementia and psychosis may receive the incorrect diagnosis of schizophrenia. In one study, 10% of adults aged 85 and over without dementia reported psychotic symptoms. In one study, 10% of adults aged 85 and older without dementia reported psychotic symptoms. For older adults living with dementia, the reported incidence of psychotic symptoms ranges from 36% for hallucinations and 18% for delusions. Symptoms of psychosis include hallucinations or delusions. Delusions and hallucinations often present together. Delusions are fixed, false beliefs. An example of a delusion is believing that radio waves can control thoughts. Hallucinations can be tactile, auditory, gustatory, olfactory, or visual. One example of an auditory hallucination is hearing voices, and visual hallucinations involve seeing objects that are not in reality. A perceived smell is olfactory. A perceived taste is gustatory. And perceived sensations such as bugs crawling on the skin is a tactile hallucination. Delusions are more common than hallucinations. Delusions tend to occur earlier, and hallucinations occur in the later stages of dementia. For persons living with dementia, there are poorer outcomes with combined delusions and hallucinations than with delusions or hallucinations alone. Specific types of hallucinations and delusions are neuropsychiatric syndromes and are often associated with certain types of dementia. In persons living with Alzheimer's disease, 30 to 61% of psychosis can be due to gene mutations. Psychosis is common in Alzheimer's dementia and less common in vascular dementia and very typical in Lewy body dementia and Parkinson's dementia. Compared with vascular dementia, the combination of hallucinations and delusions are more common with Alzheimer's disease and are associated with poorer outcomes. Delusions are more common than hallucinations in persons with a diagnosis of Alzheimer's disease. Paranoid delusions are common and often associated with theft, such as someone is trying to kill me, or someone stole my purse. Other delusions include misidentification, such as mistaking a spouse for a child. Paranoid delusions are common with Parkinson's dementia. However, dementia is not always present in the delusions for persons living with Parkinson's disease. Especially for older adults, establishing a therapeutic relationship built on trust and mutual respect is paramount. Addressing triggers and potential underlying physical causes for symptoms of psychosis are the first step in formulating the most accurate diagnosis and targeted treatment plan for the individual. A careful evaluation of psychosis and differential diagnoses include investigating an underlying physical cause that results in a delirium and presents as psychosis. Psychosis can be due to delirium. There is a depression-related psychosis. Delirium is the first priority, and the cause must be addressed immediately. Depression may also contribute to psychosis. When the underlying cause is treated, the psychosis typically resolves. When all differential diagnoses are ruled out, psychosis may be the result of disease progression. Person-centered plans focus on the person's values, goals, cultural identity, and specific diagnosis of dementia-related psychosis. About 40% of persons living with dementia do not experience emotional distress with hallucinations and delusions and respond well to non-pharmacological interventions. Non-pharmacological interventions should be considered before pharmacological interventions. Non-pharmacological interventions are those that do not involve drugs or medications of any type, including oral, over-the-counter, and herbal remedies, and are psychosocial, spiritual in nature. Agitation, aggression, disruption, shadowing, and repetitive behaviors can be improved with the use of non-pharmacological interventions. Treatment and management plans must be tailored to the syndrome of psychosis related to the specific type of dementia. It is important to identify which non-pharmacological interventions are effective in treating their psychosis in the past, and pharmacological treatment with antipsychotic medications should be used very cautiously because the antipsychotic medications carry a black box warning for increased risk of death. In summary, psychosis-related dementia is distressing to the person living with dementia and caregivers. The symptoms of psychosis are often unpredictable and require very close monitoring. One symptom may resolve and a new symptom may develop. More research is needed for biomarkers and early identification of psychosis. Similar to pain, it is important to consider that psychosis with distressing symptoms requires optimal treatment. Considering symptom clusters for syndromes of specific dementia is useful in optimal treatment and the management of psychosis to promote the highest quality of care and quality of life. Thank you for attending this session, and we hope that you'll return to view more modules on neuropsychiatric syndromes in persons living with dementia.